in Liverpool. I am the director of the Institute for Medicines in Mental Health. And I have a special interest in what we call evidence-based medicine. And many people think that evidence-based medicine is complicated and difficult. And what I try to tell people is that evidence-based medicine can sometimes be complicated, but the principles of evidence-based medicine are very easy and simple. And the key principle of evidence-based medicine is that it helps doctors to find the best treatments for their patients. And I speak to audiences across Europe and now in Central Asia. And it is very encouraging to find that wherever I go, that is exactly what doctors want. They want to find the best treatments for their patients. The first thing to say about evidence-based medicine is that it's important not to become too focused only on evidence. And if we say we have no evidence for this treatment, we must not use it. And this is a very good quotation from the astrophysicist Carl Sagan, who says that absence of evidence is not the same as evidence of absence. And if we were to look at a very important treatment for which there is very little formal evidence, there is one very good example which everybody in this room will know, which is insulin. Could you conceive of medical practice today without insulin? Of course not. And yet, the evidence from formal clinical trials for insulin is actually very small. So we must always bear in mind that if we don't have evidence, that's one thing. If we have evidence that something doesn't work, that is a different thing. And it's always important to bear that in mind. Now, what I want to talk to you about today is, first of all, to give you a very brief outline of evidence-based medicine and the way we think of it in Western Europe. And then I want to talk about this question of neuroprotection. And may I say that I think in Eastern medicine, so Eastern Europe, Russia, Central Asia, you are to be congratulated in supporting the idea of neuroprotection. And in Western Europe, I think that we are lagging behind with this concept. And I'll give some reasons why I think that has happened in a few minutes. So first, let me explain how evidence-based medicine works. And I want you to imagine for a minute that you are not doctors anymore. You are a patient. You are a patient who has had a serious stroke. Or maybe it's not you. Maybe it's your husband, or your wife, or your mother, or your father. But it is very important to make a decision about where you go for treatment. And you have here 5 hospitals that you can choose from. But how do you decide which hospital is the best one? you need some information about the doctors and the treatments that they offer in each hospital. So I will give you some information, and I will let you decide which hospital you would like to go to. So here's the first hospital. And in this hospital they say, I am a doctor. I know what's best for you. Trust me. How many people would like to go to that hospital? If you like that hospital, put your hand up. Nobody? You don't trust your colleagues? No. Hospital number 2. In hospital number 2, they say, we are very experienced, and we will base the treatment that we give you on our experience. So who would like to go to that hospital? Nobody. Okay. So, may I just say, ladies and gentlemen, that I think your Minister of Health will be very pleased, because they can now close 2 hospitals, and it will save a lot of money. Let me tell you a story about a hospital in England. 20 years ago, there was a pediatric cardiac surgery hospital. And the doctors, the surgeons in that hospital had the highest death rates of the whole of the country. And the British Medical Association, very concerned. And they said to these doctors, are you sure you're doing it right? And the doctor said, yes, we have high death rates because we treat difficult patients. But that explanation wasn't good enough. And there was an investigation. And what they found was the surgeons were not following the correct procedures. It was a national scandal. But in that hospital, the surgeons would say to parents, we are very experienced and we base our treatments on our experience. But their experience was the wrong experience, and the treatments they were offering were the wrong treatments. And that's why hospital number 2 should be closed. Let's go to hospital number 3. In hospital number 3, they say, we will do a clinical trial. And on the results of the clinical trial, we will decide which treatment we will offer you. So, which of you would like to go to hospital number 3? Anybody go to hospital number 3? A few people going to hospital number 3. Okay, because they're a little bit more scientific, aren't they? And they're applying their science to the benefit of the patients. But the science is perhaps not quite strong enough. So let's go to hospital number 4. Now in hospital number 4, they do epidemiological studies. And this in fact is my own area of research, epidemiology. And so they say clinical trials, you know, they have problems. They don't take place with real doctors, only specialists. And the patients are treated in a very specific way. They're artificial. They don't represent real practice. So we'll do epidemiological studies, which includes thousands of patients, and then we'll decide which treatment is best. So who would like to go to hospital number 4? You don't like me? Okay, hospital number 5. In hospital number 5, they say, we are very scientific. We believe that you should look at all of the clinical trials. And only when you look at all the clinical trials, some good, some bad, and then you add together all of the evidence, only then can we decide which treatment is best. So who would like to go to hospital number 5? And ladies and gentlemen, that is the right answer. And that is evidence-based medicine. And when we bring together the results of all of the clinical trials, we call that a systematic review. It may or may not involve a meta-analysis, but it provides the strongest evidence, as I'll show you in a minute. So, evidence-based medicine is not complicated. It is simply about applying a systematic process to find the strongest evidence for which treatment will give the most benefit to patients. And that is something that every doctor wants, isn't it? Evidence exists in a hierarchy, and we have the strongest evidence at the top and the weakest evidence at the bottom. So our strongest level of evidence up here, level 1A, is evidence that comes from a systematic review of multiple clinical trials. Level 2 evidence comes from a systematic review, but this time of what we call cohort studies. So these are large groups of patients, but they're not selected randomly, as they are in a clinical trial. Going down one level again, we go to level 3. And here we would look again for systematic review, but this time of case control studies. So where cohort studies are very large, case control studies are much smaller. And smaller studies provide weaker evidence. At evidence level 4, we have case series. So with case series, a doctor decides to treat 10, 20 patients with a particular treatment and records the results, but does not make a comparison with another treatment or with placebo. And then at level 5, so the weakest evidence, we have the opinion of experts like me. So my opinion, weak evidence. But the opinion of experts remains important because there are treatments for which we do not have large-scale formal studies. And the opinion of experts remains important in all of those circumstances. Now, I'd like to introduce you to 2 evidence-based medicine tools. And these are tools that any doctor, or even any pharmacist or any nurse, can use in their everyday clinical practice. And these are 2 tools that I am going to use today to review some of the evidence for neuroprotective agents. And these are tools that we use extensively in the UK today. And indeed, our Department of Health says that all health professionals should be trained in understanding and using these tools. The first tool is called, critical appraisal. And critical appraisal helps you to understand the quality of the evidence that you are reviewing. The second tool is called the number needed to treat. And the number needed to treat gives you a very easy way to understand the strength of the effect of the treatment that you are considering. You bring these two tools together, and they're both very easy to use, and you can practice evidence-based medicine every single day. So let's first talk about critical appraisal. Now, of course, we are talking about treatments for patients. So the first questions that we should ask about any information that we're going to use is about the patients. So the first question we have to ask is, are we selecting the right patients? For example, if we were talking about stroke, if we are conducting a clinical trial with a drug that may help ischemic stroke, we would not want to include patients with hemorrhagic stroke. So we must have the right patients. And then we have to ask, do we have enough patients to detect the effect of the treatment? And one of the things that you should look for in any report of a clinical trial is the power calculation, which says this is how many patients we need to have, and proves you need that many patients. Then we have to randomize. Randomization is very important because it is a natural response when a doctor is involved in a clinical trial to select the best patients. Randomization stops that from happening. It means every single patient has the same chance of getting whatever treatment as every other patient. So randomization is an extremely important part of any clinical trial. If it's not randomized, the quality of the evidence is weaker. Patients, though, have to be similar at baseline, and the groups must be treated equally throughout the course of the trial. And then all the patients have to be accounted for at the trial end. One of the things that you often see, particularly in reports of small-scale trials from the United States, is what is called a treatment completer analysis, sometimes also called an observed case analysis. And in this kind of analysis, only the patients who finish the trial are included in the analysis. Now that seems quite reasonable. But the thing is that patients who complete a trial are usually the patients who do well. But you don't know in advance whether the patient will respond or will not respond to the treatment. So you have to treat all patients. So to give a realistic assessment of whether a drug is worth using or not, you have to have an analysis that includes all of the patients. And we call this intention to treat. So in terms of quality, we must have patient randomization, and we must have an intention to treat analysis of the trial results. Very, very important. We then need to ask questions about the design of the study. So, we need a trial that is double-blind. Blinding, again, is very important. because it's not just doctors, it's everybody who likes to see or who will see the best in the things with which they're familiar. So let me give you an example. Imagine for a moment we have a doctor in a clinical trial give a patient with ischemic stroke. And in the United Kingdom, our standard treatment is to use RTPA, alteplase. Our doctors are familiar with alteplase and they know what results to expect. But we have a clinical trial and we are going to compare active aging with alteplase. In England, doctors are not familiar with active aging. They don't know what kind of results to look for or even really how to use it. So if they know one patient is on active aging, they will look less favourably on that than a patient who's on alteplase, just because of the familiarity. So we must have blinding so that every patient is treated or reviewed equally. Blinding is very important. In an ideal world, we would like studies that are placebo-controlled. That's not always possible, and it's not always ethical. The trial needs to be long enough in order for us to be able to detect the results of the treatment that we expect. Then we have to ask questions about the outcomes. We have to ask about the outcome measure. Is it validated? Has it been tested? And is it widely accepted in the community? And importantly, is it something that's important to patients? Let's say for an outcome measure in stroke, you were able to measure a change in enzymatic function. Scientifically, that might be very interesting. But you ask the patient, do you feel any better? And the patient says, no. It's not an outcome that's important to the patient. So we want outcomes that are important to patients, not just scientifically important. We would like to have a large treatment effect. In stroke, it's quite rare to get a large treatment effect. And we need to be precise about the treatment effect, which is where the statistical measures come in. And when we bring all of this together, pulling this information to assess the quality of the evidence that we have, it helps us to make better decisions for our patients. Now, you can apply critical appraisal with a simple tool which has a series of questions, and you just put the answers in here. And you can use this for an individual clinical trial, or you can use it if you're doing a systematic review. One of the things that's important to understand if you're doing a systematic review is to look at the size of the studies that are included in the systematic review. Because small studies tend to have larger treatment effects. And you may bias the overall result if you include too many small studies with large effects. And I'll show you an example of that when we look at a systematic review for Citicoline. I want to move now to the number needed to treat. Two questions are important about any treatment. First of all, does it work? Secondly, how well does it work? The number needed to treat tells you how well the treatment works. And it's very straightforward. the number needs to treat is not the number of patients that you need to treat to see one patient improve. That is a very common misconception about the number needs to treat. That is an incorrect view. The number needed to treat is the number of patients you need to treat to prevent one bad outcome. Very important to understand that. And the best number needs to treat is 1. Because that means every patient you treat, you prevent one bad outcome. That never happens. That's not quite true. There is one example where you get a number needs to treat of 1. And that is when you use an insecticide to treat head lice. Because nobody has told head lice about the placebo effect. And they all die. It is possible to get a number needs to treat of 2, which is extremely good. In Britain, the guidance from our Department of Health is that if you have a number needs to treat of 5 or less for an acute therapy, then that is a powerful treatment and you should consider using it. We don't always get 5 or less, but that's the ideal that we look for. So I want to turn now to this question of neuroprotection. And I'm going to review the clinical evidence as I see it from my perspective in England. And my perspective is very different from yours. Because in England, we do not use these treatments in neurology. Activegin is used in England, believe it or not, for sports injuries. Now in England, historically, in fact not just England, Western medicine, historically, we have taken a different approach to treatments. I don't know if anybody here is aware of the disaster that occurred across Europe in the early 1960s with a drug called thalidomide. Yeah, thalidomide. And thousands of babies were born without arms or without legs. Huge, huge scandal. And of course, the medical organizations and the regulatory authorities reacted very quickly to say, from now on, treatments must be developed in a particular manner. And so our approach has been to look for medicines that have one single function. So for example, serotonin selective reuptake inhibitor antidepressants have one function, purely on serotonin. And the idea of medicines that have multimodal treatments, now that's very challenging to Western clinicians. But it's because of our different history. And I think it's becoming clear with the science of understanding the cascade of events that happens, particularly in ischemic stroke, that single action drugs may not be as effective. Let me give you one example. We know that in the acute phase of stroke, we get release of glutamate, which causes cell damage. But later on, we need glutamate to promote neuronal plasticity. So if we have a single action drug which inhibits glutamate, it may in the long run be counterproductive. And so the idea of multimodal action, neuroprotective agents, I believe is a very important one. And it's one that eventually will be accepted in Western medicine. At the moment, there is a lot of debate about it. So let me show you how I see the evidence from a Western perspective. So first of all, there is a systematic review of clinical trials for Citicoline. But it's an old review. It's over 10 years old. And it included 4 clinical trials. Those clinical trials found that the odds ratio for a global recovery was 1.33. That, ladies and gentlemen, is a large treatment effect. It means Citicoline is over 30% better than placebo. However, there were some problems with this systematic review, and in particular, ratings on the National Institute of Health stroke scale did not separate from placebo. However, because this evidence comes from a systematic review, whether the evidence is good or bad, the strength of the evidence is level 1A, the very strongest evidence. So, in 2002, strong evidence for the use of Citicoline. But since then, we have had a very large clinical trial. So we have the ICTUS study, which I'm sure you are familiar with, for Citicoline in the treatment of ischemic stroke. And we can apply our critical appraisal questions to the ICTUS study. And when we do that, we find the patient diagnosis is correct, very large number of patients, and in terms of the quality indicators that we're looking for, they're all exactly what we would want to see. Our outcome measures are the right outcome measures in this particular indication, and generally the design and conduct of the study was very good and conforms to all the very best standards for good clinical practice, good clinical trial design. However, the results were not encouraging. The result was an odds ratio of 1.03, which meant that Citicoline was only 3% better than placebo. And when we look at the statistics, we find that the confidence interval goes below the number 1, which means statistically it is not significant. So what we have here is level 1B evidence that Citicoline failed to work in this clinical trial. However, there were problems with this clinical trial, which were only really discovered afterwards. And the first of these is that patients could be treated with RTPA. And of course, if patients are treated first with RTPA, then the opportunity for Citicoline to show a large effect is very much reduced. The second problem was there was often a delay in administering Citicoline. In some cases, patients could wait up to 24 hours before receiving Citicoline, which of course is too long. So, post hoc analyses found Citicoline clearly superior to placebo in older patients and in those with moderate stroke severity and in those patients who are not treated with RTPA. What that really tells us is this trial needs to be repeated, and it should be repeated in patients who are not given RTPA and who have moderate severity of stroke rather than high severity of stroke. There has now been a further meta-analysis to include the results of the ICTUS trial. And the results here give us a treatment effect size now of 1.14. However, you remember earlier I talked about the problems of small trials with large effect sizes. And we see one here from Tazaki and colleagues. And the effect size here is huge. 2.86 odds ratio. And we have a saying, if something looks too good to be true, then it probably is too good to be true. And the authors of this work recognized that. So they repeated their meta-analysis, but excluding the results of the Tazaki study. And this resulted in the odds ratio coming down to 1.07. So what can we conclude from all of this? Well, first of all, we have evidence level 1A, no question about that. But it tells us that if we want to be absolutely scientifically rigorous, we need to do the ICTUS trial again. And I want to turn to cerebrovascular. And again, cerebrovascular in the treatment of ischemic stroke. And this is the CASTER study. And again, I want to apply the critical appraisal approach to understanding the information that comes from the CASTER study. So if we look at our critical appraisal matrix, we find again that the CASTER study is a very well designed trial. It conforms to all the standards that we would require for good clinical practice. It uses appropriate outcome measures, and it has a very large number of patients. So this is a very good trial. However, the result is that cerebrovascular was no better than placebo. And that was true on all of the primary outcome measures, and also on all of the per protocol secondary outcome measures. Now, I have a little problem with what the investigators in the CASTER study did next, because they decided they would do a post hoc analysis of the results. Now, there's nothing wrong with doing a post hoc analysis of the results. It's the way they presented their post hoc analysis that I have the problem with. So in their post hoc analysis, what they showed was that in a subgroup of patients who had a baseline NIHSS score of greater than 12, cerebrolysin was clearly superior to placebo. That's great. I have no problem with that at all. However, they then said on 3 further outcome measures, cerebrolysin was also superior to placebo. However, when you look at the statistics, you can see that in each case, it was not, in fact, statistically significant. And this is why critical appraisal is important, because it gives you a tool that enables you to find little tricks like this. We should not condemn a treatment on the basis of one single study. Regulatory authorities in Britain always insist on the results of 3 studies before a drug can be licensed. 2 of those studies must be positive. The 3rd study can show negative results and still get a license. So my view here of cerebrolysin in the CAST study is we need more studies. We should not reject the treatment on the basis of one single study, but we should insist on more studies. The strength of evidence here is level 1B. So strong evidence that so far clinical trials have not demonstrated efficacy for cerebrolysin. I want now to turn to cerebrolysin in the treatment of dementia. And here we see a very different story. Again, we go to our critical appraisal questions, and we find that we have a well-conducted, well-designed trial with sufficient patients and good outcome measures. And the result here is a number needed to treat of 2. That is a very powerful treatment effect. And because it's such a powerful treatment effect, it's a treatment effect that we should take very seriously. And that is evidence level 1B. So we have strong evidence for a powerful treatment effect of cerebrolysin in dementia, but not in stroke. Again, it is one single study. So I think we should be asking for more studies in this population. I want to turn now to activity. And I believe that your colleague mentioned this study in his presentation. I want to show you this study because it gives us evidence of a lower quality. So if we apply our systematic review questions, we find that our selection of patients is okay, but our patient numbers are small. Patients were randomised, but the trial was not double-blind. The trial was not placebo-controlled. And the groups were not treated equally. What were the results? The results are very interesting because we have a number needed to treat of 3. 3 for activity given alone, 3 for Citicoline given alone, and 3 for the combination of activity and Citicoline. Where we see differences are in the 95% confidence intervals. And the combination treatment has a much narrower 95% confidence interval. So how should you interpret that information? The 95% confidence interval is there to tell you how much confidence you can have that that result is right. So you can have the most confidence in the combination treatment. And in patients with ischemic stroke, as you're very well aware, time is of the essence. You do not with your patient to say, well, I will try activagin, and if that doesn't work, I'll give Citicoline. These results tell us we should use the combination. So to go back to our matrix, we had a number needs to treat of 3. But here, because of some of the problems in this evidence, our strength of quality is only level 2B. It's not level 1, this is level 2 evidence. But that is still good evidence that can be applied in your clinical practice. And this has led to the design of a major clinical trial for activagin in ischemic stroke. And this is called the Artemida study. Patients can enter the Artemida study if they're over the age of 60, if they have an NAIHS score between 3 and 18, and a Montreal Cognitive Assessment score of less than 25. After 6 days, they're then randomised and treated with either intravenous activagin or with placebo for 3 weeks. After this time, they then receive treatment with oral activagin or placebo for a further 24 weeks, when we have the first primary assessment using the Alzheimer's Disease Assessment Scale cognitive subscale, the ADAS-COG, which I'm sure you're familiar with. Then we have a further 24 weeks of no treatment, and at the end of the study, there's analysis of the disease-modifying effect. If we apply our critical appraisal questions, we find that we have a large, over 500 patients have already been recruited to this study, well-designed, well-conducted study with appropriate outcome measures. We will have the results in about a year. And when we do have the results, whether they are good or bad, we will have evidence at level 1B. But it's important to emphasize here that cognitive outcomes are the focus of this study rather than neurological measures. This is a study of activagin in cognitive impairment following stroke. I want to end by showing you my piece of my own research. And what I'm looking for here are clinical trials that are randomised, double-blind, and placebo-controlled. And I'm particularly excluding small studies which can bias the results. With a systematic review, you have a search strategy. So you start looking for data. And I started using Medline, PubMed. I then used the ALOIS database of clinical trials from the Cochrane organisation. I did a manual check of references. I searched the clinical trials registry at clinicaltrials.gov. And finally, I contacted the manufacturers to ask them for any unpublished data that they might have. So these are the results of that search strategy. And following through all of these different approaches, the number of studies reduces and reduces and reduces. And in the end, I found 3 randomised controlled, placebo-controlled trials of activegin in dementia. Now, of course, it's essential to conduct a quality assessment of the trials that you're going to include in exactly the same way as if you were using the critical appraisal approach. Indeed, you do use the critical appraisal approach. And these are the 3 trials. And one of them is an unpublished study. It should be published. Now, there are differences between these trials. The first of these trials lasted for only 4 weeks and involved intravenous activegin. The second trial, again, for 4 weeks, intravenous activegin, but in a different dose and schedule. The third trial lasted for 12 weeks and involved oral activegin. So because of these important differences between the trials, it's not appropriate to do a meta-analysis of the results. The results should be shown separately, but in a way which means that you can compare the results across the studies. So what I did was to take response to treatment as my outcome measure, and response to treatment at the level that's important to patients. And these are the results. So here's the first trial with a number needed to treat of 4. The second trial has a number needed to treat of 3. And the third trial has a number needed to treat of 3. So how should we interpret these results? Well, what we find is we have 3 trials conducted at different times, in different patients, with different doctors. And yet the results are the same. And it's those same results across the different trials that gives us the power of this finding. So we have evidence at level 1A that activegin is an effective treatment in undifferentiated dementia. So this was mixed dementia. Some patients had Alzheimer's, some patients had vascular, and some had both pathologies. Now, from my perspective, in the United Kingdom, this says to me that we should be talking to the manufacturers of activegin and saying, this is potentially a very valuable treatment for patients in the UK. And it is your responsibility to conduct more clinical trials that doctors in Western Europe would find more acceptable so that we can have this treatment too. So, to conclude, recent large clinical trials, CASP trial and the ICTUS trial, have not shown efficacy for the treatments involved. We need more studies. One study that will report in about a year's time, the Artemida study, will provide important information about activegin in post-stroke cognitive impairment. In dementia, we have good quality, strong evidence for the effect of cerebrovascular and also of activegin. And finally, I think it's important to go back to the point that I made at the beginning. Absence of evidence is not evidence of absence. And in the absence of evidence, clinicians should continue to use treatments with which they are familiar and confident. It just remains for me to say, ladies and gentlemen, spasibo.